Prostate cancer is a topic in oncology where if I was standing in front of you 10 years ago, it would be probably one of the most boring lecture I would give. I would do it, of course. Very funny, but eventually I don't think I could teach you a lot. But today it's a totally different situation, and so this is my, right? Just press here and that's all? So okay. Okay, this is my disclosure. I might talk about this at the end of my lecture. And we need to, first of all, to speak a little bit about what is prostate cancer, what is the cause of the disease, and what you see here. You will see this cartoon more than one time because actually this is trying to demonstrate the cause of the disease. The curvy line is the PSA levels of a given patient. Usually most of the patients today, and you mentioned it in your introduction, most of the patients are being diagnosed when the disease is localized. And the reason why it's localized is because of the PSA test and the fact that a lot of patients, at least in the Western world, are being diagnosed because of PSA and not because of symptoms. And that's the reason why actually usually the disease is localized. But 20% of the patient will be diagnosed, 15 to 20% will be eventually diagnosed in the metastatic phase up front, and another 15 to 20% of the patients that are being diagnosed with localized disease eventually will become metastasized. So when you look on this cartoon, you may see from the left to right, if the left is the beginning of the clinical course, you can see the local disease at the left, and most of the patients, as I said, are being diagnosed with local disease, and they are admitted to radical prostatectomy or radiation therapy, or even they would be addressed to active surveillance, where a lot of patients don't really need to be treated because they won't need to be treated all of their lifetime. And a lot of the patients that are being diagnosed and a lot of patients that are not diagnosed at all are dying with prostate cancer, but not because of prostate cancer. And this is very important to remember. This is very important to explain to a lot of patients that are coming with very small burden of disease, very low grade, Gleason 6, and especially patients that are being diagnosed in their old days, they probably won't need any treatment. So these are actually the patients, most of the patients are being diagnosed here. But some of the patients, as I said, they will progress. Usually if they had localized disease, they will progress, first of all, with the PSA elevation, and eventually they will be diagnosed with metastasis. As I mentioned, some of the patients are being diagnosed up front with metastatic disease. And these patients, what we used to give these patients for years is hormonal deprivation therapy or hormonal castration treatment. And this is actually what we are doing also today. And when I'm speaking about hormonal ablation treatment, I cannot mention, I need to mention Charles Huggins. He is a Nobel laureate from 1966, and what actually is done, he is in the late 30s of the previous century. He took 21 patients that had bone metastasis. You can imagine that in these days, every prostate cancer patient that was diagnosed, it was because he had already metastasis. So they had bone metastasis, all of these patients, lymph node metastasis. And what he did actually was to do a castration, a surgical castration. And when he did this for all of these patients, 80% of these patients regressed and the disease went. And actually the disease resolved. But most of the patients, and that's what actually he was telling us in his lecture when he received the Nobel Prize, was that most of these patients eventually recurred, relapsed, and died from the disease. So, but this was a great advance, and you know, the first chemotherapy in oncology was given on 1946 by Sidney Farber, which is the name, on his name is the Dana-Farber Center in Boston where I was trained. And this happened 10 years before. So it was very revolutionized, this idea, although it seems to be very hard to do this surgical castration. But for these patients it was great because all of them suffered from pain, and suddenly it relieves, and they got another 2 years of living. And it was actually one of the more, until today, it is actually one of the most efficient treatments that we have in oncology. So based on this work and others, eventually we're starting to understand what is the biology that is underlying the disease, underlying prostate, and you can see here in this cartoon that androgens are very important in prostate physiology. They are involved in cell differentiation and metabolism and proliferation and survival, but when the tissue is becoming cancerous, then androgen becoming a very strong stimulator for proliferation and invasiveness. And that's what actually we learned. Until today, we don't understand exactly the whole mechanisms that are involved in, on this switch from differentiation to proliferation between normal cells to cancer cells. I was in Dana-Farber. I did research on a mouse model trying to ask exactly this question. And I realized that when you add some specific oncogenes to the cells and then you give them androgen, suddenly it is developed totally differently. And this is probably one of the answers that we have for this question. So eventually we isolated, you know, today all the genes are isolated, but it was a very slowly process of isolating more and more genes that are interesting in cancer. The AR gene, the androgen receptor gene, was one of them. And there are some issues today about this gene. I'm not sure I will dive into all of these issues because I don't have enough time, but it is a very important gene to understand. And the mechanism of action of androgen and androgen receptor are presented in this cartoon. You can see that the testosterone is entering the cell, the prostate cells, and it's also entering the prostate cancer cell. It is becoming, most of the testosterone becoming dehydrotestosterone by 5-alpha reductase. Then it has a much higher affinity to binding to the androgen receptor. It's bind to androgen receptor. It is becoming homodimer, entering the nucleus, and then expressing different genes that are involved in differentiation and all what it is doing, but also involved in proliferation and invasiveness when it's becoming cancer. So, looking at the physiology of the hormonal physiology, you all, I guess, know the hormonal axis, the fact that it is starting from the brain, so you know everything is starting from the brain, including our hormonal status, and the hypothalamus is secreting the LHRH, and this is actually stimulating the hypophysis gland to secrete LH and FSH to the testis. It is not in a, as you know, it's not like in a period manner like in females, but it's all the time going on, and the testosterone is secreted all the time. And when people understood these mechanisms and this physiology, then drugs were started to be developed. The GnRH analogs are today the chemical castration that we use. We almost never use surgical castration for patients unless we need a very, very fast testosterone decrease in the serum. But today we also have the GnRH antagonists, which are doing it like surgical castration. So actually there is no need today for surgical castration. There is a DHT reductase inhibitors. Usually urologists are using it for BPH or benign prostatic hypertrophy. You have the surgical castration, and you have the new drugs or the second the second line drugs, the picalutamide, which is the androgen receptor inhibitor. When we castrate the patient, we always need to remember that there is a patient out there and he suffers. And androgen ablation has a lot of adverse events. You can see here in the slide the most important ones. So they usually will suffer from impotence, or at least they will lose the drive for sexual activity, the heat flashes, the anemia, fatigue, metabolic syndrome. So patients that get this treatment for a long time, the blood glucose is elevated, the lipids are elevated, osteoporosis. So usually these patients need to get some supplement of calcium, and there are also mood instability and other issues that we need to deal with. Some of the patients are getting the treatment and are feeling just fine and continue to function. Some of the patients get this treatment and really suffer from it, and we need to remember it and to try to help them with it. I think that a lot of us sometimes forget it, and we just give the drugs, we give the injections, and we forgot about the suffer of the patient. So until the beginning of the millennium, that's actually what we had. There was no other treatment that we gave the patients. And then in 2004, docetaxel was the first chemotherapy to prove to be beneficial in terms of survival. And you can see here the tax 327 that gave the survival advantage for these patients of 2 months. But it was not only about 2 months survival benefit for metastatic patients, it was also about better quality of life, patients that suffer from pain and got chemosalinyl, the pain was resolved. And a lot of times when patients coming to me, which are usually have metastatic disease up front and they suffer from pain and they want to get painkillers, a lot of times I'm telling you, I will give you now painkillers, but the chemotherapy will be your best painkillers that we have. And this is what usually happens. They start the chemo and then they're becoming much better. Of course, that's the patients that are coming up front with painful disease. They will also get the hormonal castration, and this will be also the best painkiller. But again, at least for the castrated resistant prostate cancer patients, this is a very good painkiller that we have. So one of the recent questions that was being asked in the last decade was, and this was, so in 2004, it was approved for castration-resistant prostate cancer, right? So for the patients that received hormonal treatment for a year and a half, for 2 years, and then they progressed on castration physiology. But the question was, may we put the docetaxel up front? So is there any logic to start the treatment with androgen deprivation treatment and chemotherapy together? And the first study that was done trying to answer this question was negative. So this is the GTUG FU15 that was directed by Fizazi from Gustave Roussy in Paris. And actually this trial was negative. You can see that in terms of survival, there was no benefit for patients that received chemotherapy up front. But then came 2 other studies. One is a charter that was published just recently, and the other one is a STAPID that I will talk about it a little bit in the next slides, that have shown something different. They have shown between 10 months to 15 months of survival benefit for patients that started the chemo up front. And this was very interesting. For us, for the oncologists, it was very, I would say, we don't see a lot of this kind of trials in oncology, right? So we don't, at least with chemotherapy treatment, we don't see more than a year benefit for survival. And that's what we got here. And what they also looked on charted on this trial was if there is any difference between patients that come with a lot of tumor and between patients that come with minor tumors. Let's say with 2 metastases or 3 metastases. And they found that the chemotherapy, the patients that have the high volume disease are much beneficiaries than the patients that have the low burden of disease with 2, 3, or 4 bone metastases or lymph node metastases. If a patient had a visceral disease, which is 20% of the cases, then it is high volume disease anyway. And so when they did these curves based on subgroup analysis based on high volume and low volume disease, they've shown that most of the patients that really got benefit from this approach was the high volume patients. Now the other study was a STAPID study, and this is a study that I think that there is a lot to learn from, not only in prostate cancer, but how to design a trial. This is a British study where every patient that came to the clinic in England or Great Britain with metastatic prostate cancer was registered to the trial since 2005. And the inclusion criteria was that they need to be metastatic or node positive. The T stage is 3-4, PSA is above 40, glycerol 8 to 10, and there was a subgroup of relapsing patients, and you can see the inclusion criteria. And this was a design. So patients, when they was registered to the trial, they received either standard of care, which is ADT, right, androgen deprivation therapy, or standard of care enzohyaluronic acid, which is a bone-preserving treatment that we give, a bisphosphonate. You might have given them plus docetaxel, ADT plus docetaxel, or plus Zomera and docetaxel, but you can see that they designed some new cohorts with drugs that they thought that might work. This cohort with Celoxib, I think they stopped it early, but now they are doing cohorts, prospective cohorts with abiraterone and some other drugs that I will talk just in the next slides. And this was the way that they designed the study. They started it on 2005. They closed it on March 2013. You can see almost 3,000 patients there. So this is a very high-powered study to understand if really what we are giving up front may help in terms of survival. And you can see here the number of patients in each arm, in the arms that I'm talking about. And you can see here the failure-free survival. You can see that when you give ADT alone, after a year and a half, the patient progressed. Here it took him 37 months, which is 3 years. And in terms of and you can see that there was no difference if you add zoledronic acid or you didn't add zoledronic acid. And in terms of survival, you can see here a difference of 10 months between the patient that received docetaxel and the patient that didn't receive docetaxel. So eventually, we can sum the trials as 2-to-1 for giving chemotherapy up front. And this is the summary of all the three and some of the characterization of the 3 studies. And this is a forest plot for overall survival for the 3 studies. And you can see that when you take them all together, you have a big advantage for patients that are being treated up front with chemotherapy. So the recommendation today for patients that are coming to you with metastatic disease up front is to give ADT plus chemotherapy based on these studies. Again, we are dealing here with patients. Not every patient that will come to your office could get chemotherapy. Not all the patients will agree to get chemotherapy. Of course, there are a lot of issues that need to be solved. If the patient is performance status 4, I'm not sure if you will give him chemo. But eventually, most of the patients, this is the right thing to do. And that's what we are giving today to our patients in Israel. Now I'm moving on to the castrated resistant prostate cancer. So eventually, patients that are metastatic and getting the hormonal treatment, eventually they're becoming resistant. And now, from now on, I'm going to talk about these patients, and you can see the docetaxel that was proven to be effective in 2004. And since then, all the clinical trials that was designed for prostate cancer patients with metastatic castrate-resistant disease were characterized as pre- or post-chemo patients. And this was the way that they decided in 2008, the Prostate Cancer Working Group 2, and that's the way that these treatments were designed, these trials were designed. And you can see the whole group of new treatments that enter our clinic in the last 7 years. And you can see since the docetaxel, you can see here chemo, you can see biological, you can see here isotopes. You can see here also the denosumab. I won't talk about it because I don't have time, but we also treat the patients that have bone metastasis with denosumab, which was proven to be superior to bisphosphonates. Actually, it was a non-inferiority trial, but eventually we think that denosumab is anti-rankle, it's an antibody, is better for patients for preserving their bone, and that's what we give them. And these are the drugs that show us overall survival benefit, which you can divide them to chemotherapies, and I'm talking about cabazitaxel, novel hormone therapies, abiraterone and enzalutamide, immunotherapy, I will talk about it almost at the end, and bone-targeted therapies, radium-223. All of these drugs was proven to give us a survival benefit, and that's what we use today. So this is a list of trials for these drugs as post-chemo trials, okay? And you can see the survival data from each trial, and you can see that most of the patients, after progressing on chemo, they survived at least more than a year, somewhere between a year and a half. And what we realized, and there are some retrospective studies showing that if we add all of these drugs together, we will get more than 21 months as a median survival for these patients. It's not a prospective data, but it's a retrospective data, which says that patients that are heavily pretreated, metastatic, castrated-resistant, they still have a pretty good lifespan to live, and we should try to keep it this way and try to keep the quality of life. This is the first drug I'm talking about, the cabazitaxel. It is a chemo. It is very, very similar to the docetaxel. These are the two changes in the structure of the drug, and the idea here was to try to fight the resistant mechanism for taxanes, which is the MDR, the multi-drug resistance, and this actually was proven to work on cells, on prostate cancer cells that are resistant to docetaxel, and this is a trial that registered in the FDA, the TROPIC trial, showing a 3 months advantage of cabazitaxel versus metoxantrone, which was a chemotherapy that we used to give before. Now I'm moving on to the androgen pathway and the new drugs, the abiraterone, which is a Zytiga, and enzalutamide, which is Xtandi. And you can see here what is the mechanism of action. Abiraterone actually inhibiting the CYP17A1 and CYP17A1 that is working on the steroidogenesis from cholesterol down here to the androgens. So it's inhibiting here and here. So it's not only inhibiting the androgen biogenesis, but it's also inhibiting the glucocorticoids in the adrenal and other tissues. And that's the reason why when you give abiraterone, you need to add also steroids for the patients. And then when you give the steroid supplements, then actually the patient should be okay. But still, when you look on the adverse events of these drugs, it is pretty predictive, because the patient eventually, if they suffer from something, they will suffer from hypokalemia, they will suffer from edema, they will suffer from hypertension, and that's actually what we are telling our patients before we give the drug. The second drug is the enzalutamide that was developed as a very strong inhibitor for androgen receptor. I will talk about it a little bit later in another slide, but here the idea was to, again, to block the androgen receptor mechanism. So what led to the development of these two drugs was the understanding that when the disease is developing resistance to castration, it doesn't mean that the androgen receptor is not active. Actually, what we found out is that at least in half of the patients, the mechanism of resistance is for the disease to provide itself the testosterone. And that's why what abiraterone is doing. It is interfering with the process of the self-providing of testosterone. And the other thing we understood that if so then androgen receptor is still a major player in the game of hormonal resistance or castrated resistance disease, and that's why this was developed. So we're talking about abiraterone. This is the mechanism of action. We were talking about it. And again, the trials were two parts. The first part was done for the post-chemo. And this is the Cougar 301. And you can see here the survival benefit for these patients that got the abiraterone, which is 4 months. The second trial was for patients that before chemo, okay, in an earlier stage of the disease. This is a Cougar 302, and you can see here is that median overall survival, there is an advantage of 5 months. So there is a question when to give the treatment, right? So we'll talk about it at the end, which treatment to give when. But at least we can see that there is some advantage both before and after docetaxel. This is the progression-free survival for the Cougar AA302, and you can see that patients that was on the treatment didn't progress for a median of 16.5 months. So you can see also in the placebo that it took some time, because eventually for most patients the disease, even when it is progressing, it is not progressing very fast. So this is the reason. Now the enzalutamide, again, it is inhibiting the androgen receptor. It is inhibiting it in several stages of the process. It inhibits the binding of androgen to AR. It inhibits nuclear translocation of the AR to the nucleus, and it inhibits the association of AR with the DNA. So it is 3 phases of inhibition of the mechanism. That's why it is so strong. And here, again, you can see the AFFIRM trial for patients that was post-chemo treatment. And you can see here the benefit of 5 months for the enzalutamide arm versus placebo, and the 37% risk reduction, the hazard ratio of 0.63. And you can see here the secondary endpoint for this trial, where the progression-free survival was 8.3 months versus 2.9, which is very, very significant. We can talk about quality of life with these trials. All the trials look the same in terms of quality of life. Patients feel better when they get the treatment. A lot of the patients that I gave them this kind of treatments until today come 1 month, 2 months later and say that they are functioning again, they feel much better. And these are actually pretty good drugs for the patients that respond. Not all patients respond, right? So there is always 50% that don't respond. And this is the PREVAIL trial for patients that got enzalutamide before chemo. You can see only 2 months benefit. It's not a lot. The p-value, although it is good, but it's only 2 months. And the reason is, of course, this was a later trial. Patients that didn't receive enzalutamide in this trial, they got it later on. And that's the reason why a lot of times survival data for treatments that are being done early in the course of the disease, they have problems to show survival benefit. These are the adverse events from the trials. Again, when we are talking about abiraterone, we will see what I told you about: hypokalemia, edema, hypertension, and some other, of course. I had patients that had constipation. Some feel really bad with the treatment. And the enzalutamide, I think that the most problematic events here is fatigue. Patients are very fatigued when they get enzalutamide. We don't really know why, but this is a huge issue, and some of the patients are just, when I started to give them Xtandi, I stop the treatment and I move to abiraterone. Some of the patients that get abiraterone and they don't tolerate it, I will move to Xtandi and give it instead. Okay, so now the third group of treatments is the radium, 223. This is the isotopes, okay? So radium 223, its commercial name is Xofigo. This is an alpha emitter isotope where the alpha emitter, as you know, it's protons, so it's a very harmful and very high energy emitter, but it's moving but it's for a very short distance, only 2 microns or something. And the idea here is the radium is attracted to the bones, and it might help patients that have only bone metastasis. So there was a SIMCA study where 921 patients was involved in it. Most of them were post-chemo. There were some that were chemo-naive because they was ineligible for chemo, and they received either radium-223 or placebo, and the primary efficacy endpoint was overall survival. But I must tell you that the researchers didn't really thought that it will bring any survival benefit. They thought that it will bring quality of life benefit for patients. But eventually there was a survival benefit. Radium-223, almost 15 months. Placebo, 11.3 months. 4 months, almost, or 3.5 months benefit. And so this drug was also registered and is part of our routine practice today. I want to tell you about a new treatment that is not registered yet. Actually, today, one of the physicians told me that it is probably registered here in Cyprus, and if it is right, I'm not sure, but if it is right, you are the first country that this treatment is being registered. I'm not sure about this.
Highly likely. In Germany,
it's highly likely.
Sorry?
It is highly unlikely, yes, sir.
Highly unlikely. So yeah, so this drug, it is not registered there yet. They are working on it. Yeah. It is in a trial in Germany and in Australia, and the idea here is to combine between an antibody for PSMA and PSMA is a prostate-specific membrane antigen, which is expressed on most of the advanced cancer patients on the cancer cells. And you can see that this this part that is binding to the PSMA is binded to lutetium-177, which is beta emitter, and the idea here is to treat patients. So I think the developers in Germany thought, and I think that they are right, to give it for patients that already are heavily pre-treated. You can see here an example of a patient. So in order to get the treatment, you need first to do a PET PSMA CT that you can see. So it's a kind of a theranostic treatment, right? Because you need first to see that there is a receptor, and after you have the receptor, then you can give the treatment. Patients that don't have the receptor, they won't get the treatment. So this is an example for PET PSMA. There is a whole discussion about PET PSMA and how it is changing our practice, because PET PSMA that is in Israel is already in the basket, and we do it for a lot of our patients, letting us to see disease or metastatic disease in a much sensitive manner than the bone scan, the traditional bone scan or the CT. So this is a really improvement in our ability to see very small disease. And then the question, when you use this kind of PET CT, is how would you change your practice if suddenly, when a patient is progressing and his PSA is elevated, and suddenly you can see a very small oligometastasis, you might consider not to give him even a drug treatment, but just to give him a focal treatment with radiation or even surgery if it's a lymph node, and that's might. And I have some patients like this that the PSA is going up, and then I send them to PET CT. They didn't have metastasis before. I send them to PET PSMA, and then suddenly I see one bone metastasis. I don't do anything. I just radiate the bone metastasis, and he's continue to be in a follow-up, and the PSA is going down. Some of them, the PSA is going to 0. And then they continue their life for 2 or 3 years without any metastasis until it's going again up. And then again I'm doing PET PSMA. And then again I see another 1 or 2 metastases. I give them again focal treatment. I don't give hormonal treatment. And that's, I believe, the way for these patients to delay the hormonal treatment, to delay the adverse events, to delay the resistance to hormonal treatment. So there is no prospective study that is proving that this practice is correct, but it makes a lot of sense. And a lot of physicians, at least in Israel, are starting to do the same. And so this is just a short comment about PET PSMA, but here you can see for these patients that are receiving the lutetium, and they do have the PSMA expressed on the cells, they are doing very well. And I think that the data shows, at least for the first 130 patients in Germany that received this treatment, that at least 50% of them responded very well. And again, just remember that we don't have anything else to give them because they progressed already on biological, and they progressed on chemo, they progressed on radium, and now that's what they give, what you give them. So I have today at least 10 patients that received this treatment. All of them are heavily pretreated. 5 of them, 50%, responded very nicely. Some of them, the PSA went down from 3,000 to 0.8 or something like that. So this is a very interesting and I think important development in our field. The first patient that I sent to Germany to get treatment, now we give it in Israel, but the first patient I sent to Germany, he was with 2,500 PSA. He was anemic, he was on a wheelchair. He went to Germany. I was almost sure that he would come back not alive. And then 2 weeks later, he entering my office, walking, happy, with the color in his face. It was really nice to see. Now, 8 months after, he's progressing. He's getting immunotherapy. I'm getting there. And he's doing pretty well with the immunotherapy. So this is our next topic, the immunotherapy. So I guess you all have some clue about the immunity cycle. The idea that a lot of research led us to the understanding of how exactly the immune system is approaching the cancer. We know a lot about immune system with infectious disease, and we know a lot about immune systems and all kinds of virus diseases, but we didn't know a lot about immune system and cancer. And here you can see that there is a kind of a cycle, that it starts from the tumor when a cell is dying, and then is all these neoantigens which are shedded from the tumor, antigens that are different from the self that the immune system knows. It is entering this APC, the antigen-presenting cells, entering the lymph node. Here there is the first attachment with the lymphocytes, and here is a very major player called CTLA4, which is an inhibitor of this process in the lymph node. Then through the blood, it is going back to the tumor, and it's supposed to work, the T lymphocyte here is supposed to work against the tumor. But the problem is that there is a lot of balances. And what we learned is that there are a lot of immunomodulators that are working either here or here, which is inhibiting the process. And that's actually the reason why even if a T cell is recognizing the tumor cell, it can't be activated against the tumor cell because there are some inhibitors there that don't let him do it. And one of the most important inhibitors is PD-1 or PD-L1 that is a the ligand of PD-1 on the T cell membrane. The other thing is the CTLA-4, which is also on the T cell membrane in the lymph node. So that's actually, in general, the mechanisms, and drugs were designed to intervene with this mechanism. And the first, as you know, I'm sure all of you know that in melanoma it is a revolution. Patients, you know, in melanoma 5 years ago we didn't give anything, we just gave the old interleukin-2 and interferon alpha, which is working somewhere here, and now we understand why it never worked, or it worked only in 5 or 10% of the patients, because even if it is stimulating the cycle, eventually the inhibitors inhibiting, and there is nothing happening, right? So, and another thing that we recognized during the years is that vaccines are not working in cancer. Why vaccines are not working in cancer? Because again, they are working here. You are designing the vaccines as an APCs, as an antigen presenting cells. You design the vaccines, you tell you stimulate the cycle here and here by the vaccines, but eventually the T cells that are supposed to proliferate here and go into the tissue and kill the tissue, it doesn't work because there are a lot of inhibitors in this stage here that don't let the T cells work against the tumor. So only after understanding this mechanism and after